I'm Tim Hughes. I'm a Professor of Haematology at University of Adelaide. I'm Head of the Cancer Theme at SAMRI in Adelaide and a Consultant Haematologist at the Royal Adelaide Hospital. I've spent the last 25 years studying chronic myeloid leukemia, both at the basic level and also in the form of clinical trials. We have a large practice in Adelaide with a team of doctors interested in chronic myeloid leukemia, as well as a significant number of scientists who conduct research in that area as well. Chronic myeloid leukemia is a leukemia, which means it's a blood form of cancer, but the fact that it's chronic implies that it's long-lasting. In fact, before we had effective therapy, it still was a disease that was relatively long-lasting and that patients would stay alive for several years, sometimes more than 5 years, but it would ultimately become fatal. But since we've had the availability of effective drugs that block the active enzyme that drives this leukemia, the outcomes have improved incredibly, so that now we have survivals of around about 85 to 90% at 10 years. So most patients can live a normal life with this condition. It's basically an overgrowth of myeloid or white blood cells that come into the blood and into the bone marrow, into the spleen. Patients can present with symptoms of having an enlarged spleen. Sometimes patients just present with having a routine blood test and they're found to have chronic myeloid leukemia, and they're quite amazed because they feel perfectly well in many cases. But if it's not treated effectively, it can still be a very serious and even a fatal disease. So critically important that it's treated appropriately. These days we have very effective treatment in the form of tyrosine kinase inhibitors. The first one available was imatinib, and we now have several other what we call second generation and third generation kinase inhibitors, and they're all working towards improving outcomes for patients with CML. So I think today a patient who's diagnosed with CML has a much better outcome than a patient, say, from 20 years ago. But it's still dependent on that patient taking the therapy. After the dramatic breakthrough of developing tyrosine kinase inhibitors that control this disease, the next biggest breakthrough probably came about 10 years ago, and this was the work from the French group and from our own group in Australia, where we found that patients who'd achieved a very deep remission could actually stop their therapy altogether. We demonstrated that as long as patients had undetectable disease by the most sensitive test that we have, which is the PCR test, for at least 2 years, we could stop their drug, and approximately half the patients would stay with undetectable disease long term, and the other half would relapse and have to go back on their drug pretty quickly. So that was a very important finding, and it's led now to a change in the goal of therapy. Probably 10 years ago, our goal of therapy was to control this disease and keep patients on their drugs the rest of their life. And now we believe that we can get many patients off their drugs and remain in remission. So that becomes the goal of therapy for most patients, would be to achieve what we call treatment-free remission. The frustration at the moment with chronic myeloid leukemia is that we've had the development of second generation and third generation kinase inhibitors, and I think we were expecting that when we use those drugs, those more potent drugs, as frontline therapy, we'd see an improvement in survival. But that hasn't proven to be the case. The survival looks similar with imatinib as it does with the second generation and possibly the third generation drugs, because while we get an improvement in the response with the more potent drugs, we also get more toxicity. So the next major breakthrough in chronic myeloid leukemia will be to if we can get greater potency without getting accompanying toxicity. And it looks as though with the new drug that's been developed by Novartis, which is called asciminib, may be the answer to that equation, because it looks to have significant potency, and yet so far in the phase 1 and phase 2 trial patients, we're not seeing significant levels of toxicity. So we're quite excited about the possibility of asciminib becoming a major drug in patients with chronic myeloid leukemia. One of the problems that we have today is that the second generation drugs, nilotinib and dasatinib, both have more toxicity than the first generation drug, imatinib. And that does lead to difficult decisions about best therapy. We know with dasatinib that there's a significant risk of developing a pleural effusion, and that can be a difficult thing to treat. It's very rarely life-threatening, but it can be quite difficult. We know with patients on nilotinib that there's an increased risk of vascular complications such as heart attacks and strokes. Once again, it's not a huge risk, but it does increase the risk from the baseline level. So we need to keep these things in mind when we choose our drug. If a patient has significant lung and heart problems, then we may well steer more towards imatinib or Gleevec as our preferred treatment, because that's incredibly safe in those settings. But sometimes patients need more potent drugs, and then we have to weigh up the toxicities versus the potential advantages of the more potent drugs. And I think the most important thing, if you do decide to use those drugs, is to be very vigilant. With the dasatinib, be aware of the possibility of a pleural effusion. With nilotinib, make sure that you've controlled the risk factors such as the elevated cholesterol, the elevated blood sugar, the weight, the exercise, all those things we need to do to minimize our risk of vascular events. I think it's very clear that if we can do that, we can minimize the potential added risk of the nilotinib therapy. The most common question that I receive from my patients is, when can I stop my drug? Because most patients today have heard about the possibility of stopping. They know a few patients who come to the clinic that have now off drug. They know that about half of them are staying off drug long term, and they want to know when they can stop. So that's a very important discussion. It's one that we used to not want to deal with too closely because we thought that it was probably going to be only achievable by a small minority. But the more we understand about treatment-free remission, the more we feel that with very proactive approach, we can get many more patients into treatment-free remission. So that discussion is one I welcome today. And if there's a patient who's had, say, a year of drug and is doing well, they might say, I've done pretty well, when can I stop? And then we'll have a discussion about the fact that you need to achieve a deep molecular response. You can't contemplate stopping until you've achieved what's called a deep molecular response, which means what we call a 4-log reduction, which is a 10,000-fold reduction from the starting level. Once you get to that sort of level, and many patients do get to that level, and you maintain it for at least 2 years, then we can start talking about the possibility of stopping. And so that's a conversation that I have with many patients, possibly most patients. And timing is the big question there, because if you attempt to stop too early, it's less likely to be successful. But if you wait too long, then you've left the patient on drug unnecessarily. So it's a difficult conversation today, and we need to develop better ways to predict who can stop successfully and who should wait. For most patients who develop chronic myeloid leukemia, it's a terrible shock. As I said before, many of those patients had no idea they were unwell, and yet they had a blood test that suggested if they don't do anything about it, it could be a fatal condition. So it's a very tough time for patients. And they have to make difficult decisions because they do have choices. At the start of therapy, we now have 3 drugs that are available as frontline therapy, and more drugs available if patients don't tolerate or don't respond well to those drugs. So there's a lot of complex decisions to be made. And while the clinician is very happy to help with those decisions, ultimately a well-informed patient is in a much better position to make a shared decision with the physician rather than simply take it all on trust from the physician. I think that's, it gives you more power in the system. But I think the Leukaemia Foundation plays a really important role in that. I know a number of my patients are involved as advisors because they have a huge experience, and they can be very, very helpful for a patient who's just been diagnosed with chronic myeloid leukemia to talk to them and get some perspective on the disease and how they've faced up to the challenges over the past 10 or 15 years that they've had the disease. So that's very, very valuable. There's also expert advisors Leukaemia Foundation have available to talk to patients as well, so it's great value.